हो गया। देखो कितने बच्चे हैं, कुछ आए मालूम पड़ता है। तो फ़ोन पे भी देख सकते हो।
हाँ जी।
लोग दफ्तर से भी करते हैं, नीचे आके करते हैं?
नहीं सर, कोई ऑफिस से भी करते हैं, घर से भी करते हैं।
अच्छा, घर से भी करते हैं। तो उसका घर ऑफिस से कर पाते हैं लोग आराम से?
हाँ सर, गूगल मीट से करते हैं।
अच्छा, गूगल मीट से करते हैं। गूगल मीट चलता ही नहीं है। अच्छा, ये भी गूगल मीट है?
नहीं, ये सब दूसरा है सर।
ये कौन सा है, सरल है?
नहीं, इन्होंने कुछ अपना ही वो लिंक बना हुआ है टेलीमेडिसिन वाले में।
तो क्या सरल से लिंक्ड है?
ये सर LT2 कुछ करके बनाया हुआ है सर इन्होंने। AIIMS LT2 लाइव स्ट्रीम यूट्यूब बनाया हुआ सर।
यूट्यूब पे तो क्लासेस हो तो रही हैं ठीक तरह?
हाँ जी सर।
गायनी की और पीडियाट्रिक्स की भी हो रही हैं?
हाँ जी।
सुबह होती हैं? सुबह होती हैं 8 से 10?
सुबह 8 से 9 सर, और 10 से 11।
तो सुबह एक गायनी होती होगी और एक पीडियाट्रिक्स, क्या हो रहा है सुबह आज?
नहीं सर, अलग अलग होता है। जैसे गायनी का होता है मंडे को, उन्होंने मंडे को भी डाला हुआ है, सैटरडे भी डाला हुआ है।
हाँ।
और बीच में कल वेडनेसडे भी डाला हुआ है। वैसे डाला हुआ है इन्होंने किड सेक्शन वालों ने। और पीट्स का मंगलवार को।
इनका एक ही हो रहा है आजकल?
मंगलवार को भी है सर, और एक दिन हो रहा है, 2 दिन है सर। जैसे आज भी
भी कोशिश यही कर रहे थे उनकी फीस और कहीं ख़त्म कर दें इस अगले 1.5 महीने में, ताकि फिर अगले सेमेस्टर में जो अगला सेमेस्टर आएगा उसमें फिर टाइम मिल जाएगा इन लोगों को वॉर्ड जाने के लिए। ये सोच के बना रहे हैं। ये सब लेक्चर हैं जनवरी के।
हाँ, 2021 के
इनको यहाँ लाए हैं, बस खाली बैठे हैं बच्चे। कितने आगे लोग आए हैं अभी? यानी
सर 2 है सर।
2? कितने 2 मिनट और के क्या करें?
कर सकते सर, वो आते ही इतनी नहीं उनका।
हाँ,
2 स्टूडेंट हैं, एक आरुषि करके, एक उमंग करके।
Coming from the OPD, this takes so much time nowadays.
There are 2 speakers and 2 students, so don't worry. You can say, I can introduce.
Dr. Sandeep Agarwal and anosmia, he did test it with him. He said he will do his part from there.
Right.
He said जब मैं finish करूँ तो phone करूँगा।
आप बैठ जाओ, आप बैठो। जब आप 5 मिनट पहले इसको बता दें, ये फ़ोन कर देगा। आप फ़ोन कर देंगे या आप फ़ोन कर देंगे।
मैं करती हूँ।
शुरू करें फिर? Because they're just 2 students, we'll just begin anyway.
Sir, I don't think anyone joined. उस दिन वो नेफ्रोटिक फिल्म कर रहे थे, कोई भी नहीं था.
Which is bad. उसका फायदा क्या है ये कर रहे हैं?
Sir, well, पहले भी कहाँ होते थे जब कोविड नहीं था. You remember the first time we did this talk on 2nd January? There were just 3 students and you actually said let's walk out. It's no point.
चलो शुरू करता हूँ, इसकी स्लाइड ला रही नहीं. ये ऑन है, माइक ऑन है. Hi, good afternoon. So we would have the today's seminar. बंद कर दो, आप अपना फ़ोन बंद कर दो. The topic of today's seminar is renal replacement therapy or kidney replacement therapy, which would be the new kind of a modified definition in which we are replacing renal with kidney to make it more understandable for lay public as well. You have had classes on chronic kidney disease wherein we discussed that the concept of chronic kidney disease and how it's classified from class 1 or stage 1 to stage 5. And stage 5 chronic kidney disease really implies, if you look at that in terms of the glomerular filtration rate, a GFR of below 15. So that was CKD stage 5. And if you kind of try to look within CKD stage 5, as the kidney dysfunction worsens, you reach a stage wherein you really can't manage without some sort of renal replacement. And this renal replacement could be in the form of dialysis or transplant, and we'll be discussing as we go through this seminar today regarding the various modalities that are possible. So clearly, once you are in advanced CKD stage 5, you are probably heading for the need for some kind of a kidney replacement. In this sense, in fact, nephrology is distinct from other specialties because you are able to offer kidney replacement, wherein while there are ways by which you can offer kidney replacement compared to say cardiology or to even liver, where once the organ fails, there is no option but to do a transplant. And while in nephrology, you can often postpone the need for a transplant to long periods of time, and often often indefinitely. And there have been reasonable advances, as Shramita will discuss with you as she goes through, in being able to provide renal replacement strategies which are obviously novel, and they are not really novel, but they are patient friendly, and they are obviously compatible with long-term survival. Now, when do you think about initiating renal replacement therapy? And I'm sure Shramita will be discussing this more. But the timing of renal replacement therapy really is at a stage when you can't survive without these modalities. And this typically corresponds to a GFR of about 6 to 10 or 8 to 10. Again, there are various guidelines that would say different ways. But overall, once the GFR falls below 10 or 12, one would start thinking of initiating renal replacement. And definitely, if it's further lower, like 6 to 8, clearly there is an urgent need for replacement. Now, at times, the patient may start showing symptoms even before this. So there could be intense nausea, vomiting. In children, we often see growth retardation. So if kids are not growing, even at a GFR of say 15 or say 12 or 14, we would often think about transplanting these kids or initiating some sort of renal replacement much earlier. So while we do have a GFR figure, this figure is not really sacrosanct, I would say. And if you have biochemical disturbances, or if you have symptoms or clinical features that suggest that the need for renal replacement, or the need that once you initiate renal replacement you'll get better, one would often initiate RRT at a much earlier stage. Now, what are the modalities that we have, and we'll be discussing this as we go through. Again, the modalities that we have in nephrology are peritoneal dialysis in its various forms, and we'll discuss that with you. Then we have hemodialysis in various forms, and they will again be discussed. And then you have the option of kidney transplantation. Each of these modalities has its own benefits, its own drawbacks. In children, for example, kidney transplantation is often considered to be the modality of choice. chiefly because it enables a child to go to school, attend to his normal activities and so on. But there are a number of factors that would be operative, then that would determine, which modality one chooses. And I must say, that it's not that you choose a modality. You often, decide to follow one modality, and as the patient gets better on one, so you could start with hemodialysis, and once your patient is ready, for a transplant after say 6 months or a year, you could shift to transplant. If the transplant is working well, you are doing well, it's okay. But if the transplant fails, say at the end of 2 years, he's again back on renal replacement, which could either be peritoneal or hemodialysis. So very often, both children as well as adults may end up getting more than one or maybe even more than two forms of renal replacement therapy in their whole lives. And I'll probably end the introduction, by also mentioning to you, there are major issues regarding ethics of transplantation. And these issues of ethics of transplantation really center around, the cost considerations, the long-term benefits, the long-term survival, and these are, at times operative at the extremes of age. How do you manage a child who is say 1 year old, who has got end-stage kidney disease or who requires renal replacement therapy, vis-a-vis a 40-year-old man who is clearly much more productive to the society, and so all these things have to be weighed in carefully in relation to the economics, in relation to other issues as well. So there are major issues regarding ethics as well as, long-term outcomes. None of these modalities would lead to improved kidney function. They are just supplanting or, just supplementing the kidney function, which is anyway declining at a constant rate. I'll probably stop here, and Dr. Bagchi will now go over the various modalities with you, and after that we'll have some discussion by Dr. Sandeep Agarwal on the surgical aspects of kidney transplantation. Dr. Bagchi, can you join? Thank you. Thanks.
So I'm going to talk to you about kidney replacement therapy, as Sir said earlier. And kidney replacement therapy, when we come to the point of discussing renal replacement or kidney replacement therapy, it means that the patient cannot function, sustain life with his or her own kidney function, the level of function he is at that point of time. So when you talk about the functioning of the kidneys, one thing we need to remember, it's not just the excretion of the waste products and the resultant regulation of electrolyte and fluid level in the body, but and maintenance of acid-base balance, but it also has some endocrine functions. When we talk of failing kidneys, the simplest way we have right now of monitoring is still the blood urea and the serum creatinine and the estimated GFR based on serum creatinine, and which gives us a rough idea when a patient requires replacement therapy. Renal replacement therapy is broadly classified into dialysis and transplantation, and dialysis is further classified into hemodialysis and peritoneal dialysis. I'll be discussing each of them in detail subsequently, and the type of modality selected is not just based on the clinical condition of the patient. Obviously that plays a big role, especially the hemodynamic stability of the patient, but available infrastructure, affordability, and a patient's decision, especially for long-term replacement therapy, also have an impact on the type of treatment the patient eventually gets. So starting with dialysis, when does a patient need dialysis? A patient may need immediate short-term dialysis sometimes if a patient has an acute kidney injury, and you have had a seminar on acute kidney injury in detail, so I'm not going to go into that. And the patient may need long-term dialysis or transplantation if the patient goes into advanced chronic kidney disease, or what we call as CKD stage 5D. You know that patient chronic kidney disease is classified 1 to 5 based on the estimated GFR, and once the patient is in stage 5 and requires dialysis or transplant, it's classified as stage 5D. Now, when should we advise a patient to start dialysis has been a issue of controversy for a long time. Initially, it was thought that early initiation would be more beneficial, and if a patient went into stage 5 and the GFR dropped below 15, that would be the time to advise dialysis initiation. But subsequent studies have shown that that really does not give any survival benefit to patients. So now the practice is more that the patient should be started on dialysis usually with the when the patient is symptomatic for the loss of kidney function, and arbitrarily that usually happens when the GFR is between 5 to 10 ml per minute. So what are the symptoms which would suggest that the patient is now will now need long-term maintenance dialysis? Persistent GI manifestation, persistent nausea and vomiting, which does not resolve with medical therapy, severe malnutrition, severe anemia, severe bone mineral imbalance causing severe hyperphosphatemia, uremic neuropathy, and if all these complications are not managed optimally with medical therapy, it means that this is the time when the patient needs to start dialysis. Sometimes it becomes an emergency. Patients may need to be immediately initiated on dialysis when you're seeing the patient has hyperkalemia or severe metabolic acidosis, severe hypercalcemia, fluid overload leading to acute breathlessness, acute pulmonary edema, uremic pericarditis or pleuritis, altered sensorium suggesting a progressive uremic encephalopathy or a bleeding diathesis. So these are indications which may be present in acute kidney injury as well as chronic kidney disease which has progressed and at that point needs an emergency initiation of dialysis. So the concept of dialysis or cleaning the blood of urea and creatinine and waste products which are accumulating in the blood due to the failing kidney function has been there since the Middle Ages, and people have used multiple therapies like sweating therapies, bloodletting using leeches, and even enema to get the urea creatinine out of the blood. But the first concept of diffusion and osmosis was given by a Scottish chemist in the early 1700s, and that even now forms the basis of hemodialysis and peritoneal dialysis. So when you look at the kidneys, basically the main job in the kidneys, if you put it simplistically, it's a filter. So blood from circulation comes through the renal artery into the kidneys, and it passes through this multiple millions of filtering units or nephrons, where the excess excess electrolytes, solutes and water are filtered out, and they pass through the renal tubules, and where again certain more alterations are made in its composition by secretion of solutes and reabsorption of certain solutes and water, and so the final product is the urine, which carries all the waste products, while the filtered blood is returned by the renal vein. So the filtration process is guided by a net filtration pressure. So this is how the nephron unit looks like. This is the tuft of capillaries or the glomerular capillaries, and the blood enters from the systemic circulation through this afferent arteriole, and it is filtered in these capillaries. So these capillaries have a lining which is the inner endothelium, followed by the glomerular basement membrane and the outer podocytes, and they together form the glomerular filter. Through this filter, the fluid and the other substances, solutes, pass into this Bowman space, from where it goes into the tubules. This is mediated by the glomerular hydrostatic pressure minus the colloid osmotic pressure and the capsular hydrostatic pressure. So the net filtration pressure is around 10 millimeter of mercury, and this is something which the dialysis process tries to mimic. So what are the concepts on which fluid and solute removal in artificial dialysis based on? So in the earlier days when the concept of dialysis was evolving, the dialysis unit used to be called the artificial kidney lab, because people were trying to mimic the normal kidney function through the hemodialysis process. And so there are two components when we are talking of dialysis: this fluid removal and solute removal. So the fluid removal in hemodialysis, if you think of this tube as an artificial dialyzer, the blood is passing through this tube and there is dialysate fluid outside. So there has to be an exchange between the two. The fluid has to move from the blood to this dialysate, and for that a transcapillary pressure or a transsurface pressure across the surface is applied, and that pressure will push the fluid out into this dialysate fluid. The other thing that happens is there is a difference in the concentration gradient or the osmolality between this fluid and this. So if the osmolality over here is higher, the concentration is higher, then that will draw in fluid, while if the concentration outside this capillary is higher, it will draw the fluid from the blood. So the concentration gradient and the transcapillary pressure applied will push fluid out, will filter fluid out. The solute exchange is slightly different. It occurs by diffusion mainly, where there is movement of solute across the membrane from high concentration to low concentration. So this blood in the tube has a higher creatinine and urea level because the patient has kidney failure, while the dialysate fluid here has no urea creatinine. So since the concentration is higher over here, the urea and creatinine will diffuse out into the dialysate fluid, so the blood gets cleaned out. The second thing that happens is the convective transport. When you are applying pressure to cause ultrafiltration, as the fluid gets pushed out, it also drags solutes out. The solutes dragged out are usually those which have a smaller molecular size compared to the solutes which have larger molecular size. So fluid removal is mainly by ultrafiltration, while solute removal is by diffusion as well as by convective transport. So coming to hemodialysis. The hemodialysis is basically the blood is drawn out of the patient's body. It's cleaned up in a machine, and then the clean blood is sent back into the patient's body. So the dialyzer, which is the membrane, instead of the glomerular basement membrane and the endothelium glomerular filter, there is a dialyzer, which is a semi-permeable membrane, and the blood is passed across this semi-permeable membrane. The dialysis process is usually done 2 to 3 times per week, and each session lasts 4 to 5 hours. It is usually done in the hospital, but now home hemodialysis is emerging as an alternate for patients who cannot come to the hospital 2 to 3 times a week. It is actually widely practiced in patients in countries where the population density is low and patients live in remote areas like Canada and New Zealand. It's available in India, but it's expensive since you have to set up the infrastructure at home. So how did the story start? The first successful hemodialysis occurred towards the end of the Second World War. Dr. Wilhelm Koch, he designed this machine, and to be very honest, this was even used in this institute in the early 70s when the dialysis, 60s and 70s when the dialysis had just started. So this is the Kolff rotating drum. If you see this container has a dialysis fluid, and this drum basically has cellophane tubes tightly wrapped around it, and the blood is taken from the patient and passed through these tubes. So the blood is inside these tubes which are wrapped around a drum, and this drum is inside this, submerged inside the dialysate fluid, and this drum keeps rotating. So every part of the drum basically gets submerged, comes in contact with the dialysis fluid. So there's blood on one side of the cellophane membrane and there's the dialysis fluid on the other side of the membrane. So diffusion, convection, everything happens. Of course, this was a very crude thing, but it worked. The first time they used it, the patient actually had an acute kidney injury and he was dialysis requiring, and after a week he was discharged with a normal kidney function. We've come a long way since this called rotating drum, and so I'm going to discuss the present day hemodialysis machine. Basically, it has a blood circuit and a dialyzer circuit. So what is it? We're taking out the blood from the patient, cleaning it up and returning it. So the blood circuit, it starts from the patient. The vascular axis, there is a way to draw blood out. So there are two ends. If you see the arterial end and the venous end. So the arterial end, the blood is drawn out from the patient's body. It goes to the dialysis machine and then it is cleaned up and sent back through the venous end. So this is an AV fistula, arteriovenous fistula. So when a patient is at chronic kidney disease stage 4 or early stage 5, we counsel the patient to make a fistula. I'll discuss the fistula in the next slide, but this is an easy way because the patient just comes and lies down and 2 needles are put in and connected to the dialysis machine. This venous and arterial end both have air detectors, so that by mistake air should not enter into the circulation from the machine, because it can cause air embolism, which is fatal. The blood is drawn out from the patient at a very high rate. It's almost 300 ml per minute. So that's why I was saying the patient's hemodynamic stability is very important. If the patient's blood pressure is already low and you draw blood at such a rapid rate from velocity from the patient, then obviously there is a chance of the BP falling further, and he may go into a cardiac arrest, or he may not tolerate the procedure. So this is what the arteriovenous fistula looks like in a pictorial format. What is done is a vein which is superficial is connected to the artery, and it's a small procedure. It takes around half an hour, and the blood flow from the artery goes through the vein. So over the time, because of the high pressure to low pressure movement, the veins wall gets thickened and the vein becomes prominent. So it is easy to cannulate the vein, and because the blood flow is better in the vein due to this fistulous connection, you can draw blood out at 300 ml per minute for the dialysis. So this arterialization of the vein usually takes 6 to 8 weeks. So if you make a fistula today in a patient, the patient can, if it is functioning, the patient can use it only after 6 to 8 weeks. This is an access of choice because there is no foreign body involved. It's the patient's own tissue, and once it's done, the patient can take long-term dialysis through this access. But sometimes the veins are not good enough. You may not have a superficial vein through which can be connected to the artery, and AV fistula is not always successful, especially in patients who are diabetic or elderly or have atherosclerotic disease where the vessel wall is thickened or calcified. So what are the other alternatives? The other permanent alternative is an arteriovenous graft, where a synthetic conduit is connecting the artery and the vein. So herein, even if your vein is thin or superficial, this conduit can be cannulated for putting in a fistula needle. So the fistula needle doesn't go into the artery or the needle, it goes in the vein, it goes into this graft. Only problem is it is synthetic, so obviously it has a higher chance of clotting and thrombosing and closing down, and it also has a chance of infection. It can be used earlier once made compared to an arteriovenous fistula. Now sometimes you have a patient who has had no follow-up and suddenly comes with a creatinine of 13 and potassium of 6, or a patient has an acute kidney injury. You don't have time to make an arteriovenous fistula or a graft. So for that you need to put temporary catheters. Temporary catheters are routinely put in the internal jugular vein or the femoral vein, and they are dual lumen catheters. So the catheter will have 2 lumens. One will serve as the arterial end to draw out blood, and the other will serve as the venous end to send the blood back to the circulation. Again, there are two types. One is tunneled and one is non-tunnel. The non-tunnel catheters are just for emergency use, and they should not be used for more than 1 week in case of femoral catheters and 3 to 4 weeks in case of internal jugular vein catheters. Well, there can be tunneled catheters which look something like this. Here the catheter is inserted here but comes out over here, so it's inside the tunnel, which reduces the risk of infection, and that can be used for a longer period of time. But then these are foreign bodies, and they have a higher complication rate, especially infections. Now once you've drawn out the blood, you have to pass it through a dialyzer membrane. So this is how a dialyzer membrane looks like. So we've come a long way from the Coles rotating drum. The tubings which were there are there here also, but they are very small, and they are packed inside this container. And basically they are hollow fibers which are used to be made of cellulose, but now usually they are synthetic. And so they can be reused. You can clean up this dialyzer and you can reuse it up to 7 to 8 times in the same patient. You cannot use one patient's dialyzer in the other patient, but in the same patient you can reuse it for 7 to 8 times. And the dialyzer size, how big a dialyzer you will use, depends on the body surface area of the patient. So children will need smaller dialyzers, while adults will need larger ones. So when we are dialyzing, we try to mimic the renal physiology. So the blood comes in, and from this top end it is passed through the dialyzer, where it is passed through this hollow fibers, while dialysis fluid is pushed in from the lower end. So the blood flow and the dialyzed flow are in opposite direction. Counter current flow of the kidneys is mimicked over here to maintain the maximum concentration gradient. As I said earlier, the concentration gradient decides not only solute movement but also fluid movement. So to maintain the concentration gradient, there is a counter current flow. As we saw earlier, the blood flow is 300 ml per minute, while the dialysate flow will be around 500 to 800 ml per minute. So what is the dialysate? The dialysate, basically it starts with the normal tap water, but obviously you cannot let the tap water come in contact with the patient's blood. It can cause serious reactions, infections, many complications. So there is a very sophisticated reverse osmosis plant in the dialysis unit which cleans up the water, and then electrolytes, acid and a bicarbonate are added to that filtered water to create the dialysis fluid. We have to be very careful about the water being used in the dialysis fluid preparation, because in a 4-hour dialysis session a patient is exposed to around 120 to 200 ml of 200 liters of water, which is quite a lot. So you cannot afford to have any contamination in that water, and there are strict guidelines to prevent contamination. There should be no toxins, no colony forming units in the RO plant. Multiple factors are there. The dialysis fluid, as I said, as you can see here, tries to mimic the plasma composition. The only thing is the potassium content is lower. Usually potassium free dialysate is not used nowadays, because that can cause severe hypokalemia in a patient and even cause cardiac arrest. There is an buffer. Nowadays we usually use a bicarbonate buffer, and glucose is added to the dialysate fluid so that the patient does not develop hypoglycemia. So this is how the modern day dialysis machine looks like. You have a fistula, the patient's blood is drawn in, the dialyzer is attached over here, the blood goes in. There is a water source connected from behind this machine, so the water is supplied. This is the part A, and part B, the electrolytes and the acid and the base, which is sucked into the dialysis machine, mixed with the water, and which then is pushed into the dialyzer from here. So the dialysate fluid moves up, the blood moves down, it gets cleaned up, and then is sent back into the patient's body. There are multiple pressure monitors to monitor the transcapillary pressure, the transvenous pressure which is applied to achieve the ultrafiltrate. There is so we give anticoagulation to the patient during dialysis because the blood is passing through this artificial tube. It can clot, which can have serious consequences. So heparin is pushed into the circulation from here, and there are various heparin prescriptions decided depending on requirements, whether there isn't a problem and there is any air in these tubings or there is any leak in the blood. There are multiple detectors kept here, and the screen here you can impute what you want to give. So suppose you want to give a 4-hour dialysis session and you want to ultra filter 2 liters of fluid during that. So you put in 4 hours and you put in 2 liters. So the machine will remove 500 ml per hour of fluid. And you can also see what is the osmolarity of the dialysate, which is an indirect estimate of the electrolyte and the electrical charge, which determines the sodium content. You can vary the sodium content of the dialysate fluid, and you can also add potassium into the dialysate fluid if a patient has hypokalemia. But hemodialysis is a complicated procedure. It brings down the urea creatinine and the patient can live for years on maintenance dialysis, but it has its share of problems. When we are initiating a patient of dialysis, especially the patient has a very high blood urea, say 250 to 300, then suddenly bringing down that urea levels can cause changes in the osmotic concentrations in the brain, because the neurons get adapted to the high urea level, and sudden movement of urea and can cause cerebral edema leading to dialysis disequilibrium. That's a typo, it should be dialysis disequilibrium. And patient usually will have headaches, or it can be something simple as a headache, and it can be something serious like altered sensorium and convulsions. So how do you prevent dialysis disequilibrium? If a patient has advanced chronic kidney disease and is very uremic, say his blood urea is 270, 300 or even higher, so you don't start the patient immediately on 4-hour sessions of dialysis. You ease him into the process. So the first day you give him 2 hours dialysis, the second day maybe 3 hours, the third or the fourth dialysis session should be a full session. So that way the urea doesn't drop down drastically and the cerebral edema does not develop. The dialyzer reactions used to be common earlier when cellulose and semisynthetic membranes were used for dialysis, but nowadays it's less common. Still can happen if the dialyzer is not properly cleaned up, and patient may have allergic reactions. As I said earlier, blood is removed at a flow of 300 ml per minute during dialysis, so it can cause rapid fluctuations in blood pressure, which can cause severe hypotension. It can also cause fainting, vomiting, cramps, chest pain, especially in patients with underlying cardiac disease, and if a lot of fluid is removed, it can cause fatigue. So because of these rapid fluctuations in fluid removal as well as electrolyte removal, patients on hemodialysis have a high risk of sudden cardiac death, especially in those who have underlying cardiac disease. Also, you have to understand that hemodialysis does not bring the creatinine to normal. A normal person's GFR is 120 ml per minute. Hemodialysis, each session gives you 3 to 5 ml per minute. So if you have 3 dialysis sessions a week, that is around 15 ml per minute. So no way it is anywhere near a normal kidney function. And that is why the creatinine will never come to normal. And despite continuing on hemodialysis, patient will have to maintain stringent fluid and dietary restrictions. So because you cannot remove more than 2.5 liters of fluid during a dialysis session, it will cause severe hypotension. So if you drink more than that, then obviously the patient has fluid overload and can go into pulmonary edema. So to prevent that, fluid restriction, salt restriction, potassium restrictions all need to continue. And there is a risk of hyperkalemia and fluid overload in between sessions for patients who are not compliant. Successful continuation of hemodialysis requires a vascular access, that is a lifeline of a dialysis patient. So if a fistula cannot be made, or a fistula thrombosis, or there is a catheter and there is a catheter related bloodstream infection, these are all problems which arise from time to time. Since it's a procedure which involves handling of blood, there is a risk of transmission of infections, bloodborne viruses, especially hepatitis B and C, and that is the reason strict asepsis universal precautions are recommended, and any lapse can lead to transmission of infections. Patient has to go to the hospital 3 times a day, has to lie there for 4 hours, so really it disturbs the life. I mean, patients sometimes go into denial and depression. And in countries like India, availability is an issue. People in rural areas, even if they can afford and even if they require it, sometimes they don't have access to dialysis unit, and it's not feasible for a patient to travel 200 kilometers 3 times a week for getting dialysis, so that becomes an issue. So then people started thinking to overcome these complications, what was the alternative? One of the alternatives considered was peritoneal dialysis. So in peritoneal dialysis, there is no artificial dialyzer. The peritoneal membrane serves as a dialyzer membrane. The access, instead of a fistula, graft or a catheter, is a PD catheter which is inserted into the abdominal cavity, and the dialysate fluid, instead of passing through the dialyzer, is pushed into this abdominal cavity where it comes in contact with the peritoneal membrane. So the peritoneal membrane has capillaries inside it, and these capillaries carry the blood. So the blood is on one side of the peritoneal capillaries, and the other side there is this dialysate fluid, and the exchange happens. So you need a healthy peritoneum to do peritoneal dialysis, and patients with peritoneal scarring, laparotomy cannot do it. Patients unable to care for self, obviously, because this is a procedure which is done at home, and but the good part is you do not need any infrastructure. You don't need to come to the hospital. Once the catheter is inserted, the patient can do the dialysis at home. When we talk of PD nowadays, we are usually talking about continuous ambulatory peritoneal dialysis, which is given to CKD 5D patients as a maintenance dialysis. But in the earlier days, acute peritoneal dialysis was also given as an emergency procedure, where a straight rigid catheter which was inserted into, basically a fluid was pushed into the abdomen to create ascites. Once the ascites was created, a straight rigid catheter was inserted with a stellate inside it. Stellate was removed, and then directly the fluid was connected to this catheter. So the procedure could be started immediately after inserting the catheter. The risk of complications are very high, especially of infection and peritonitis, so it could be used only short term, 2 to 3 days, as an emergency procedure. It is seldom used nowadays, especially in developed countries, but we still use it from time to time and it is still a modality, life-saving modality in areas which have limited access to hemodialysis. So when we talk of modern day PD, we are talking of continuous peritoneal dialysis, which was quite a late development. It came 30 years after the hemodialysis, after Kolb's hemodialysis. So this is how the CAPD catheter looks like. There is so it is inserted into the abdomen. There is an adapter here. There is a transfer set and a clamp. It is closed like this, and the patient carries this along it's there continuously. This is the PD bag, the dialysate fluid. It is connected over here, and these bags are usually 2 to 2.5 liters. So the fluid goes in through this, it gets disconnected, the patient keeps doing whatever he wants to do, and after 6 to 8 hours, again an empty bag is connected here and the fluid is drained out. So you're connecting something over here and the fluid is going inside, so chances of introducing infection are very high, and so an aseptic technique is very mandatory. Now what is a fluid which is being pushed in? A dialysis solution, standard dialysis solution, again it tries to mimic the serum, the plasma constitution. The characteristic thing with PD is there is no potassium in a PD solution. So a hemodialysis fluid has a lower potassium level than plasma, while a PD fluid will have no potassium. This is very important. It will have a buffer as in HD, it will have lactate or a bicarbonate or a combination. Now you have to understand that in hemodialysis the ultrafiltration is achieved by applying a transcapillary pressure which pushes the fluid out, and by the concentration gradient. Now, the peritoneal, in the peritoneum you cannot apply a transcapillary pressure, so you need an osmotic agent to draw the fluid. The dialysate fluid should have a higher concentration gradient than the patient's plasma to pull out fluid. And this osmosis higher concentration gradient is created by putting in a dextrose. So different strengths are available, 1.5, 2.5 and 4.25. And sometimes when these don't work, you can use something called nicodextrine, which is a polyglucose which is slowly absorbed from the circulation, so it stays in the abdomen for a longer time, creating the concentration gradient and facilitating the ultrafiltration. One thing we need to know is that the peritoneal membrane is quite leaky, so when you expose it to the dialysate fluid, there will be protein loss in the PD fluid, and the patient may lose up to 8 to 9 grams of protein per day. So PD patients on peritoneal dialysis need to have adequate protein in their diet. The loss of protein can also cause inflammation, increasing risk of peritonitis. And other substances may be lost in the dialysate along with the protein, and we need to supplement them. But the good part is that there is less dietary and fluid restriction. The peritoneal dialysis is done daily, unlike hemo. So daily there is some loss of fluid. So you do not need to maintain the kind of fluid restrictions you do for hemodialysis. And it's a gentler procedure. There is no blood removal at a high rate. So the hemodynamic fluctuations and hypotension seen with HD are not seen in PD. This is simply how much independence it gives to the patient. The patient can do it himself, disconnect the fluid, it enters the abdomen by gravity and he throws away, and he's set to go, and he after 6 to 8 hours will come back and again drain the fluid out and put in one more bag inside. So these manual exchanges are done 3 to 4 times a day. This can also be replaced by a PD cycler machine. I'm not talking about it, but it is basically a machine to which the patient gets connected at night, and the machine will push in fluid into the abdomen and draw it out throughout the night. So instead of the patient doing it manually, it is done at night, so it gives more freedom to the patient. PD is safer than HD in some aspects, but it has its own complications because it's a tube which has connected and disconnected daily in the abdomen. There's a risk of infections. It can be an exit site infection, it can be infection in the tunnel in which abdominal wall where the catheter lies, or it can be a peritonitis. Non-infectious complication, the catheter may get blocked, the patient may be constipated, and that can cause obstruct the catheter, or it can move. There may be pain. Sometimes the peritonitis, repeated inflammation can cause sclerosis in the scarring in the peritoneum, and it may stop functioning, so there may be an ultrafiltration failure. The patient has a hernia, which is a contraindication for doing peritoneal dialysis. But if a patient develops hernia, it can lead to fluid movement into the hernial space, and because of loss of protein, it can cause hypoalbuminemia, which can lead to hypertriglyceridemia. Glucose content in the dialysate can lead to hyperglycemia and weight gain. Now, looking at peritoneal and hemodialysis, they can keep a patient alive without transplant for years, but as I said earlier, it does not replace the kidney function totally. So the GFR replaced is only a part of the normal GFR, so it's not 100%. Also, it does not replace the endocrine function. The kidneys produce erythropoietin, which is needed for hemoglobin production. It produces vitamin D for bone metabolism. So those functions are not replaced by dialysis. You still need to replace them with medications. The dietary restrictions continue. The procedure has to be continued lifelong, so obviously it limits the freedom of a patient, and it's in the long term it's more expensive than renal transplantation in India. So we come to renal transplant, which is the holy grail currently for management of chronic kidney disease patients with end stage kidney disease. So the concept of replacing an organ has been there for a very long time, if you look at history and mythology, and but there have been barriers. The biggest barrier was how to keep a patient alive when the patient developed a kidney failure till he underwent a transplant, which was overcome by the advent of dialysis. Second thing was overcoming the immunological barrier. You're taking a kidney from a genetically different person, and giving it to another person, there is a very high chance of that recipient's immune system would reject it. The third thing is, how would you take out the kidney and donor kidney and preserve it till you transplanted it. So first transplant happened, successful transplant in 1950s in Brigham Hospital in Harvard. It was a monozygotic twin donor, and as you can see, it was very differently done compared to what is done today. The genetic identity was confirmed by multiple things, but not by the HLA, which was still in a developing stage at that point. It was hypothesized that no immunosuppression would be required, and the recipient actually survived for 9 years, and his kidney was functioning when he died. So in the modern era of transplant, where the third kidney is put usually in the right iliac fossa, the patient is undergoing a second transplant, sometimes in the left iliac fossa. The surgical aspects will be discussed by Dr. Agarwal, so I won't be going into that, but this is how the scar looks the graft kidney is placed over here in a patient. Who can donate a kidney? It can be a live related, first degree relative of a patient, like parents, siblings, children. It can be biologically unrelated but emotionally related, that is a spouse, and it can be an unrelated altruistic donor. And it can be a deceased donor who can be brain dead, which is usually the norm, or a non-heart beating donor who cannot donate a kidney. So a donor is undergoes a detailed evaluation. You know, the ethics, the basis of medical ethics practice is you do no harm to someone else. So you cannot harm a healthy person to keep another person alive. And so we need to know that the person who is donating a kidney has no medical condition which will risk his complications for general cause complications during surgery. And we should also know that the removal of that one kidney will not put the donor at any further risk, especially of developing kidney disease in the long term. So a prospective donor first undergoes a psychiatric evaluation detailed to understand that he has under no pressure to give the kidney. He understands that long term he needs to take care of himself, he needs to undergo lifestyle changes. Like if he's a smoker, he needs to stop smoking, he needs to lose weight because he's going to have to live his life on a single kidney. Then the medical evaluation starts. First, of course, the renal function. A patient has to have 2 healthy kidneys to be able to donate one. If his kidney function is per se subnormal, then you cannot donate a kidney. The cutoff for the GFR for donating is 80 ml per minute abroad. In India, since the mean GFR is lower, we take a cutoff of 70. So 70 ml per GFR at least. And both the kidneys should have equal function, because out of the 70, one kidney is 20 and the other is 50. If you give that 20 to the patient is not going to benefit much. And you cannot give the healthier kidney to the patient, obviously, because that would push the donor into chronic kidney disease. The donor should not have any urinary abnormality, any structural abnormality, and no history of any hereditary renal disease in the family. Then comes the cardiovascular or pulmonary disease. Diabetics cannot donate a kidney because diabetes is the commonest cause of chronic kidney disease. So you cannot leave a diabetic with a single kidney. Hypertension, well controlled with no target organ damage, can donate. Underlying cardiac condition or chronic pulmonary disease, they cannot donate a kidney. Infectious disease, extensive workup for infectious disease should be done, because first thing is, with infection, undergoing a procedure for that donor is risky. Second thing is that he can transmit, that donated kidney can transmit the infection to the recipient, so which is risky again. And any patient, a patient should have undergo a malignancy screen to rule out a underlying malignancy. Once we decide as a nephrologist that okay, we have done all this thorough extensive workup and the donor is fit to donate, then we send the patient for a surgical evaluation. Then comes the immunological barrier. So the immunological barrier is now decided by the HLA antigens, which are a set of 6 antigens on the cell surface coded by the chromosome 6. They're classified into class 1 and class 2. Class 1 is HLA-A, B, and class 2 is HLA-DR. And these 6 antigens decide the extent of matching. The matching is better among related donors like father to son or mother to son or son to brother to sister. And the degree of matching is decided by the mismatch. So higher the mismatch, this is how the report comes. So this is the recipient, this is the donor. So the higher the number of mismatches, the poorer the compatibility. So if you are related, you will have at least 3 antigen match. That is a good match. It's called a haplo match or a 50% match. But the number of mismatches increases with the unrelated donor. Then once, obviously you will not get a twin donor all the time, and even with a parent you will not have a full match, right? You will have a 50% match. So there will be some degree of mismatch between the HLA antigens, and this can lead to production of antibodies, presence of so we need to look if there are antibodies against the antigens which do not match. So what we do is we mix the donor cells with the recipient serum. So if the recipient serum has antibodies against these donor cells, it will cause cell lysis. Cell lysis indicates a positive cross match. A positive cross match, especially with the cell lysis, means you cannot take that donor for transplant. You put that kidney in the recipient, the patient's body, the recipient's body will reject that kidney. There are other ways of looking for antibodies, donor specific antibodies and panel reactive antibodies, which decide the immunologic compatibility between the patient and the donor. Why do we need to do this? Because rejection is used to be the most fearful complication of transplantation. When these advanced matching techniques were not available, when the kidney was put, sometimes if there was antibodies already present in the recipient's serum, as soon as the kidney was connected to the recipient's artery and vein, the kidney would reject. Within minutes the kidney would turn blue. That was called a hyperacute rejection, which is rarely seen nowadays. There could be an accelerated rejection, an acute rejection, or a chronic rejection. Acute and chronic is what we still see from time to time, though it has come down very late nowadays. So to overcome the risk of rejection, we try to suppress the immune system of the recipient so that he tolerates the donor kidney. And these immune system suppression drugs have to be taken lifelong. They target multiple pathways. I'm not going to go into detail, but mainly they target multiple pathways which inhibit T cell and B cell proliferation. And we know that B cell produces the antibody, the T cell has the cell mediated immunity, and suppressing both of them helps in preventing immune mediated rejection. So how is it done? It starts with an induction therapy, which is a high dose of immunosuppression given just before the transplant is done, just minutes before the transplant is done or hours before, to suppress the immune system while the kidney is being connected. It consists of a high dose of steroids, usually a pulse methylprednisolone. In related donors, a corticosteroid pulse would suffice, but sometimes if the immunological matching is not very good, we may need to give a higher level of immunosuppression, which usually comprises of a T cell depleting antibody or an interleukin 2 receptor blocker called basiliximab, which also inhibits T cell proliferation. Once the kidney is connected and the body accepts the kidney, we continue the patient on maintenance therapy, which usually starts a few days before the transplant to get the body used to it. The maintenance therapy consists of oral steroids, prednisolone, which has a broad immunosuppressive effect, a calcineurin inhibitor, which again inhibits the T cell proliferation, an mTOR inhibitor, or an antimetabolite. The antimetabolite inhibits both T and B cell proliferation, and then there are newer drugs coming up like belatacept. So what is the combination maintenance therapy usually used? In our center we use prednisolone with tacrolimus, which is considered to be more potent than cyclosporin, and mycophenolate mofetil. So it could be MMF or azathioprine, tacrolimus or cyclosporin, and prednisolone. Why kidney transplant? You have to find a donor, you have to do a matching, you have to do a detailed evaluation and a operation. So why so much of pain? Because it reduces morbidity, Patient once transplanted just has to be on medications and regular follow-up. He doesn't have to come to the hospital every week or like hemodialysis, or he doesn't have to do peritoneal dialysis at home for himself 3 times, exchanging twice and thrice every day. He can go back to work. Hospitalization rates are lower, long-term expenses are lower, and most important, mortality advantage. Look at this graph. These are the patients who are on dialysis. This is a patient who has got a marginal kidney, like an elderly patient who is hypertensive, not very good kidney. And this is a patient who has got an ideal kidney. So if you see, the risk of death is, even with a marginal kidney, is lower compared to dialysis. So any rate, at any point, a transplant gives a huge survival advantage to a patient compared to dialysis. There are some patients who cannot undergo a transplant. If you don't have a donor, of course, you can't undergo a transplant. If you have cytotoxic antibodies against HLA antigens of that donor, so you're a CDC cross-match positive, you cannot. If a patient has stiff psychiatric illnesses and you know that the patient may not take his immunosuppressive drugs, you do not transplant that patient, because even 5 years after a transplant, if a patient stops taking his drugs, his body may reject the kidney. Any full-blown infection, including AIDS, HIV is not a contraindication of transplant. If it's controlled with heart, your CD3 counts, CD4, CD8 counts are good, you can undergo a transplant, but not if you have full-blown AIDS. Severe extrarenal disease like cardiac disease, advanced pulmonary disease, where the survival advantage is lost. Or where the patient is too sick to be able to tolerate the transplant surgery. Any active kidney disease where there is a chance of recovery or there is a chance of recurrence after transplant, we should wait and watch. Metastatic malignancy or a recent malignancy. Uncorrectable lower urinary tract disease is a relative contraindication, because if you have a lower urinary tract disease which has caused the chronic kidney disease, then and it has not been corrected, then even the transplant kidney will be lost. Morbid obesity again makes a surgery more difficult, but it's not a absolute contraindication. Certain metabolic disorder, primary oxalosis causes oxalate crystal deposition in the kidneys and loss of kidney function. So if it is a genetic disorder, there's a problem in the liver metabolism of oxalate. So if you do just a kidney transplant, the oxalates will again get deposited in that kidney. And so if you have primary oxalosis, you do a liver and kidney combined transplant. You don't do a isolated kidney transplant. As I said earlier, complications of infection, it used to be rejection, but with the newer drugs available, the rates of rejection have come down. It used to be 20-30% earlier, now it's less than 10%. Infections are a big problem, especially in countries with a high infectious disease burden in the community like India. Infections are the biggest complication, the most common cause of mortality and hospitalization in transplant patients. We should have a very low index of suspicion because they are immunosuppressed. Cardiovascular disease is the commonest cause of mortality in transplant in developed countries. In India also, as transplants are being more successful, patients are living longer, this has become an issue. The post-transplant immunosuppressed rate and the use of certain immunosuppressive drugs increases the risk of certain malignancies, especially lymphoproliferative disease, lymphomas. And all these immunosuppressive drugs have their own side effects, so they have to be used lifelong, and they come with their own issues. So to summarize, patients with kidney injury, kidney disease, advanced loss of kidney function will require renal support. If they have an acute kidney injury, they may require temporary support till the renal function recovers, so they are a candidate for usually dialysis. Patients with CKD, chronic kidney disease, progressing to end stage 5D will need lifelong renal replacement therapy, so they are a candidate for transplant or dialysis. Transplant has the best outcome in any situation, but it is limited by the paucity of donors. And if the patient does not undergo a transplant and needs to select dialysis, it will depend on the patient's medical condition, availability and affordability, and of course at the end it's the patient's personal choice whether he is willing to do a procedure at home and prefers the independence of that thing, or he wants to go to the hospital thrice a week and leave his medical care in charge of to the hospital. Thank you. Professor Sandeep Agarwal will be joining you shortly.